Okay, welcome back, guys. Today we're going to be talking about our respiratory system as well as associated pathophysiology. During this lecture and towards the end, we're going to be, mentioning disease states like pneumonia and chronic bronchitis, emphysema, asthma, COPD, that type of thing. But in order to get there, we need to first establish a baseline for some of the microscopic components, including the anatomy and the histology, to get to those disease states. Now, first of all, we have to kind of address the fact as to what the primary overall functions of our lung are. And really, the primary functions of our respiratory system winds up being to provide efficient gas exchange between the inspired air that we breathe in as well as with systemic circulation. Now, we have to keep in mind that the air that we breathe in, just regular atmospheric air, is not 100% oxygen. It is roughly in the neighborhood of maybe 19 to about 21% oxygen. The majority of the gas component that we breathe in is actually nitrogen. So we have to kind of keep that in mind. So we are breathing in oxygen enriched air, and we are primarily breathing out carbon dioxide enriched air. So the air that we breathe in is higher in oxygen compared to carbon dioxide, and the air that we breathe out, that we exhale, is higher in carbon dioxide in relationship to oxygen. But it's not completely devoid of oxygen. That's one thing that we have to kind of keep in mind. And the way that we can prove that is because of CPR. If the air that we breathed out was completely devoid of carbon dioxide, then CPR, in other words, mouth-to-mouth resuscitation, would never work. So we have to kind of keep that in mind. So in healthy individuals, this process results in adequate oxygenation of our blood with the subsequent removal of carbon dioxide. All right, so as we know, the lungs are located within our thoracic cavity, encased within a rib cage and the sternum. And we have to kind of appreciate the fact that the important structures within our body, the important organs within our body, really happen to be very heavily protected. If we can think about, let's say, for example, our brain, for an example. Our brain is encased within our skull, and certain textbooks actually call the skull our cranial vault. So it is that important that we have something called a vault protecting it. And the same thing exists with our lungs and our heart. These two key structures are so important. These two organs are so important. They are encased within an actual cage called the rib cage. So that gives you a certain different level of appreciation of vital key structures and organs within our body, that they are that heavily protected. So our lungs, as you know, are made up of this spongy, elastic type tissue that stretches and constricts as we ventilate. So as we breathe in, the lungs expand because they are made up of elastic, non-rigid tissue. And as we breathe out, the lungs go back to their normal shape and size because, once again, they are elastic. So very similar to what we see with something like a rubber band. If we stretch out a rubber band, it exerts a certain level of pressure, but when we let go of that pressure, then the rubber band comes back to its original shape and form because it is elastic. And so are our lungs. That's an important concept to understand as we discuss pathologies later on. Now, the airways that bring air into and out of our lungs, namely our trachea and our bronchi, are made up of these alternating rings of smooth muscle as well as cartilage. Now, if you recall, we have no conscious control over smooth muscle. We do have conscious control over skeletal muscle. However, we do not have conscious control over smooth muscle or cardiac muscle. So thank goodness for the alternating rings of cartilage that we have within our trachea. along with the smooth muscle, because we know of a disease process known as anaphylaxis, where people can develop these life-threatening allergic reactions where their airways can close up. And our airways we have no conscious control over because they're made up of smooth muscle. So if we didn't have those slightly rigid cartilage tissue in alternating bands within our smooth muscle trachea, then our trachea would completely close and we could unfortunately die. So it's a fantastic safety mechanism there that our trachea is made up of these alternating patterns of smooth muscle as well as cartilage. Now that allows for our airways to constrict and to expand during our respiratory cycle. The lungs and the airways that bring oxygen-enriched air and eliminate carbon dioxide, which is produced by our cells. So just to keep in mind that the whole function of our respiratory system and of our lungs is to breathe in air, but to get that oxygen, which is in the air that we breathe in, to our target tissues, to the cells within our body. Remember, within our bodies, we are made up of billions upon billions upon billions of cells, and every single one of those cells has a need for oxygen to be able to do whatever that cell was designed to do. And it is our respiratory system that allows us to get the oxygen out of the air that we breathe in and into our cardiovascular system so that the red blood cell can bring it to the target tissues, bring it to those cells so that the cells can acquire that oxygen and do whatever it is that they were designed to do. Now, as a waste product, when the cells finish doing what they were designed to do, like manufacture an enzyme or manufacture a neurotransmitter or a hormone or what have you, well, they generate waste products, and one of those waste products happens to be carbon dioxide. So just like the red blood cell brings the oxygen to the cell, well, the red blood cell also picks up carbon dioxide to bring back to the lungs so that we can exhale it out on our next respiratory cycle. So the air that we breathe in, as you know, is not 100% oxygen. The atmospheric air that we breathe in is only about 19 to about 21% oxygen. The majority of the gas that we breathe in is actually nitrogen. So the air that we breathe in has all of these gases, and then the air that we breathe out has carbon dioxide within it. And it's not completely carbon dioxide. Remember, there is a slight fraction of oxygen within the air that we breathe out as well. And the reason we know this is because, well, not only can we measure it, but if that was the case, if we only breathed out carbon dioxide rich air, well then mouth-to-mouth resuscitation or CPR would never work because you're blowing in expired air from your body into inspired air into the person that you're giving CPR. So remember, a fraction of the air that we breathe in contains oxygen, and as we breathe out, the majority of the air that we breathe out has carbon dioxide, but a very small fraction of oxygen. And then the last bullet, the lungs also help in regulating the concentration of the overall hydrogen ion concentration within our blood. And that's just a fancy way of saying that the lungs help to maintain the overall pH of our blood. And as you guys recall, the pH of our blood happens to be within the range of 7.35 to 7.45. And if you guys remember from high school chemistry, remember we have that pH scale. We have a pH of 1, which is very, very acidic, and somewhere we have stomach acid, which is in the neighborhood of, about 1.2 to about maybe 2.2. That is where we see stomach acid. And then we have on the other end, we have pH of 14, which is very, very alkali or very, very basic. And right in the middle is the pH of 7, which is completely neutral. In other words, it's not acidic and it's not alkali. It's neutral. But the pH of blood is not neutral. It's 7.35 to 7.45. So that means that it is slightly alkali. It's not exactly neutral, our blood. Here you can see a picture of the airways that show the alternating pattern of the smooth muscle and the cartilaginous tissue of our respiratory tree. And it's so funny when you think about it, it looks like an inverted tree with all of its branches without any leaves. And that's exactly why they call it a respiratory tree. We can see here that each one of the bifurcations, like our main stem, our primary main stem bronchi, and our left and right bronchi, that is a bifurcation. So if we were to, for example, take a look at this here, that is bifurcation number 1. If we take a look at this here, well, that's bifurcation number 2, as well as bifurcation number 2 over here as well. So each time the airway splits, that's called a bifurcation or a generation. And there's some researchers that estimate that by the time we get to all of these microscopic bifurcations that we see here leading up to the terminal structures that we know of as alveoli, there are up to 23 levels of generations. So 23 levels of bifurcations, all the way leading up to that those microscopic terminal structures that we know of as alveoli, where gas exchange takes place. If we take a look at this picture here, we can see that our left lung is made up of 2 lobes and our right lung is made up of 3 lobes. The right lung area has larger area availability because it doesn't have that portion missing for the heart itself. That's why on the left side, the left lungs can only form into 2 lobes because the heart is taking up a majority of the area within the thoracic cavity on the left side. All right, so this slide is just really meant to demonstrate the overall relationship of our lungs and our respiratory passageways in relationship to anatomically and geographically the structures located on our body itself. If we take a look at our, clavicles, we can see here that the tops of our lungs really, if we feel the clavicles on our own bodies, we can kind of imagine that underneath that structure is the top portions of our lungs. And then the bottom portions of our lungs, we have to kind of remember that they sit right on top of the major muscle of inspiration, which happens to be our diaphragm. So as we breathe in, the diaphragm descends, expanding our overall thoracic cavity, and the air naturally comes in and it just inflates our lungs. So when we look at the overall pathway that air utilizes to enter into our lungs, as we breathe air in through our nose and through our mouth, it goes past our epiglottis and into our trachea, which we said is made up of those alternating rings of smooth muscle as well as cartilaginous tissue. It continues down the trachea through our vocal cords into the larynx until it reaches the bronchi. And from the bronchi, where we see a bifurcation, from the bronchi, air then passage into each respective lung, the left and right primary main stem bronchi. Air then follows narrower and even narrower bronchioles until it reaches that terminal structure that we know of as the alveoli, where gas exchange takes place. Okay, so this slide really is just meant to further demonstrate some of the structures that we've talked about thus far, like our larynx and like our epiglottis. And what I want to focus your attention to are these tiny grape-like sacs here, which are sitting at the terminal ends of the smallest air passageways known as bronchioles. And these tiny grape-like sacs are known as alveoli. And what I want you to kind of further appreciate from this picture is just how heavily encased these tiny grape-like sacs are with respect to the pulmonary capillaries. And we kind of have to remember that the pulmonary capillaries, well, this blood is very, very low in oxygen and very, very high in carbon dioxide. The air that is being brought into the alveoli, well, that air is high in oxygen and low in carbon dioxide. So this is where the gas exchange for our bodies takes place within our respiratory system. It occurs at the level of the alveoli. Okay guys, for this next slide, I needed to turn on my camera because there's an important concept that I needed for you guys to be able to visualize. So if we were to take like a regular a regular bottle, like a water bottle or a Coke bottle, etc. And if we take a look at it, it is very similar to what we see within our thoracic cavity. For example, with this water bottle, what we see is that through the top, there's only one way in and one way out. Very similar to our thoracic cavity, where there's only one way in and one way out. Now, we have to understand that there's air within this bottle, even though it's an empty bottle. So if I was to apply pressure from the outside and squeeze the hell out of this bottle, then what's happening to the pressure on the inside of this bottle? The pressure is actually increasing, all right? And supposing if I had imaginary handles on the outside of this bottle, and if I was to pull apart using the handles, the imaginary handles on the outside of the bottle, pulling apart the walls of the bottle, well, what's happening to the pressure on the inside is that it is decreasing. So remember, if I'm squeezing, applying force from the outside, the pressure on the inside is increasing. If I'm pulling apart the walls of the bottle, then the pressure on the inside is decreasing. That's an important concept that we need to appreciate when we're talking about the thoracic cavity, because upon inhalation, what happens is that the diaphragm and the intercostal muscles contract, expanding the thoracic cavity. That's kind of like us pulling on those imaginary handles on this water bottle. This lowers the pressure in the thoracic cavity below the atmospheric air pressure. Now, the atmospheric air pressure at sea level, where we are, happens to be 760 millimeters of mercury. So what happens? Well, from high pressure to now low pressure in our thoracic cavity, air then naturally goes in. And we see this related concept throughout the entire science field. We always see high pressure to low pressure. Like, in other words, blood flow from high pressure to low pressure, diffusion from high concentration to low concentration, temperature from high temperature to low temperature. There's always this net flow from high to low. So when we have the inhalation, upon inhalation, the diaphragm and the intercostal muscles expand. The diaphragm descends and the intercostal muscles pull out. This lowers the pressure within the thoracic cavity, lower than the atmospheric air pressure. Then naturally, air from the outside comes in, high pressure to low pressure, and inflates our lungs. Now, when we exhale, that's like our diaphragm and our intercostal muscles squeezing or relaxing, making the cavity smaller. So they're squeezing on this water bottle. What's it doing? Well, it's increasing the pressure within inside the water bottle. It's increasing the pressure within our thoracic cavity, higher than the atmospheric air pressure. So naturally, this decreasing volume of the cavity increases the pressure in the thoracic cavity above the atmospheric air pressure. Well, we know this phenomenon from high pressure to low pressure. Air from the lungs, which is under high pressure, then just naturally leaves the airways to the outside air, which is under low pressure. And this cycle just keeps repeating itself with every single respiratory cycle. Okay, so this slide is just really meant to demonstrate that upon inhalation, what winds up happening is that the diaphragm moves down. So as the diaphragm moves down, this expands the thoracic cavity. Air then naturally just comes in from high pressure to low pressure because the pressure within the thoracic cavity decreases. If we take a look at the diagram on the right, well, upon exhalation, what's actually happening is, well, the diaphragm moves back up because it relaxes, thereby compressing the thoracic cavity, making the cavity smaller. Thereby, the pressure within the thoracic cavity is higher. So then naturally, from high pressure to low pressure, air gets expelled out. Okay, so another structure that's important within our thoracic cavity is this structure known as the pleura. Now, the pleura is the outer covering of our lungs, and it's also the internal covering of the thoracic cavity itself. And what's unique and special about the pleura is that it serves as an anti-friction device. Within this space, there's a tiny little amount of fluid, about the amount of a medication cup, about 30 mLs of fluid, and that fluid is known as pleural fluid, and it serves as an anti-friction device. What I mean by that is that we have to appreciate that within our bodies, we have something that's constantly moving 24/7. So if we have something constantly moving within our bodies, well, that is generating friction, and we can't have that. We have to minimize this friction. So just like in the engines of our cars, we have engine oil, which reduces the friction of the pistons that are moving up and down in the engine, and the movement of the pistons up and down is generating force, which is driving the car. Here, we have pleural fluid serving as that anti-friction device. In our cars, we have engine oil serving as that anti-friction device. Okay, and the last structure that we'll talk about is the alveoli. And as I mentioned to you guys before, the alveoli sit at the terminal ends of those smaller and smaller airways known as bronchioles. So here what we're talking about is really on the microscopic level, and these alveoli have the appearance of these tiny, tiny grape-like sacs, and this is where gas exchange takes place. And I just want you to recall that all of these alveoli, all of these tiny grape-like sacs, are nestled within or completely surrounded by these capillaries, and this is where gas exchange takes place within our respiratory system. Once again, here's another picture of how these tiny grape-like sacs known as the alveoli are nestled within and are completely surrounded, are completely networked by this pulmonary capillary bed. So the exchange of gases between the inhaled air that we breathe in and blood takes place across these points of contact between numerous alveoli and the surrounding pulmonary capillary networks. So as we take a closer look at these alveoli, one of the things that I want you guys to kind of appreciate is that within these air sacs, the oxygen concentration is high because the air that we just breathed in has a higher concentration of oxygen compared to carbon dioxide. And that's what these brackets mean. That means concentration. So what happens? Well, oxygen diffuses across the alveolar membrane into the pulmonary capillary, onto the red blood cell. Now, on that red blood cell that's passing by the pulmonary capillary, well, oxygen binds to the hemoglobin and carbon dioxide winds up being released. Carbon dioxide is also released from sodium bicarbonate, which is dissolved in the blood of the pulmonary capillary. Now here, the carbon dioxide concentration is high in the pulmonary capillary, and the carbon dioxide concentration is low in the alveoli sac, air sac. What happens? Well, then carbon dioxide leaves blood and passes across the alveolar membrane into the alveolar air sac. All right, so there are a couple of important concepts on this slide, and the first important concept when we take a look at the animation that you are looking at in front of you is the close proximity of the alveolar air sac to the pulmonary capillary bed. So we can see here that literally it is almost just 1 or 2 cell layers thick. That is how close the proximity is of the pulmonary capillary bed to the alveolar air sac. Now, once again, remember, the air that we're breathing in that we find within the alveoli, that air is high in oxygen, low in carbon dioxide. The red blood cells that are coming by at that junction, that red blood cell is high in carbon dioxide and low in oxygen. Well, if it's high in carbon dioxide and in the alveolar air sac there is low carbon dioxide, well then naturally carbon dioxide is going to go from the pulmonary capillary bed off of the red blood cell into the alveolus, high concentration to low concentration. And if the air that we just breathed in is high in oxygen and the red blood cell has very low oxygen, well then naturally oxygen is going to just diffuse from the alveolar air sac into the pulmonary capillary bed and onto the red blood cell. That's why the animation shows a bluish purplish color coming to the alveolar bed, and as it's leaving it is a more reddened color signifying oxygen-rich blood returning back to the heart. And this exchange of oxygen and carbon dioxide is so fast that it takes less than 1 second. In fact, it's faster than a lightning strike. That's how fast oxygen diffuses onto the red blood cell from the alveolar air sac, and how fast carbon dioxide diffuses across the pulmonary capillary bed into the alveolar air sac so that it can be blown off on the next expiratory cycle. So the carbon dioxide leaves the alveolus upon exhalation, and the oxygen-enriched blood returns to the heart via the pulmonary veins. So therefore, really the purpose of breathing is just to keep the oxygen concentration high and the carbon dioxide concentration low in the alveoli so that this gas exchange can occur via diffusion. Now, one should note that our respiratory cycles, our inspiration and our expiration, are under autonomic nervous system control. So what that means is that it is our autonomic nervous system that is taking care of this function. We don't have to consciously think about it or consciously work at breathing. That is just taken care of automatically, as our other vital functions, like our vital signs, like our blood pressure, our respirations, our heart rate, our temperature control. All of this is happening automatically by our autonomic nervous system. But as you recall from anatomy and physiology, even though it's occurring automatically, that doesn't mean that we can't influence it. However, like for example, if we were to hold our breath, our autonomic nervous system will actually wind up overriding our action, forcing us to let out that breath and start breathing again. So many of us who, like, let's say for example, swim or who enjoy swimming, we have to hold our breath underwater as we are swimming. Well, we can only do that for a certain period of time because our autonomic nervous system will actually override our conscious action of holding our breath, thereby forcing us to let out that breath and then to start breathing again. And these automatic or autonomic control centers are located within the brainstem and the medulla. So what that means is that there are these specialized nerve cells that actually reside within these specialized centers that automatically send signals to the diaphragm, which is the major muscle of inspiration, and our external intercostal muscles to contract and relax at regular intervals. So what this is telling you is that there is a pacemaker for respiration, and that pacemaker is located within the brainstem and the medulla. Now, these pacemaker cells of respiration located in the brainstem and in the medulla, they can be influenced. For example, the oxygen level. So there are specialized nerve cells that are located within our aorta and within our carotid arteries, which are called peripheral chemoreceptors. And all they do is they monitor the overall oxygen concentration of blood, and they send feedback to those respiratory centers located within the brainstem and the medulla. So if the oxygen concentration in the blood winds up decreasing, like going below that 95% that we're always checking on our patient's pulse oximeter, if they go below that, there is a stimulus that is shot up to those respiratory centers to increase the rate and the depth of breathing, thereby bringing our oxygen saturation above the 95%, closer to 100. But not just our oxygen level. The carbon dioxide level can also influence these respiratory centers. For example, we have those same peripheral chemoreceptors. Well, they can detect not only the oxygen concentration, but they can also monitor the carbon dioxide concentration within our blood. And then there is also a central chemoreceptor within the medulla, which monitors the carbon dioxide concentration in our cerebrospinal fluid. Now, carbon dioxide diffuses very readily into our cerebrospinal fluid from our bloodstream. So what happens, these chemoreceptors, if if the carbon dioxide concentration gets too high, well, both types of these chemoreceptors will shoot a signal or shoot a feedback loop to those respiratory centers to, once again, increase the rate and the depth of respiration. You want to blow off all this excess carbon dioxide, so you are hyperventilating. This increased respiratory rate winds up returning the carbon dioxide concentration back to normal. And then once that happens, your respiratory rate begins to decrease. So here you can see on this slide where these chemoreceptors are located, and they are very strategically located. And what I mean by that is, if we take a look, and this is just a representation of the heart and the aortic arch, we have these chemoreceptors that are located right at the level of the aortic arch itself and right at the level of the internal carotid arteries. So here, these internal carotid arteries. And how perfect is it that we have these receptors that are right there checking the blood that's exiting the heart, checking the oxygen level of that blood, as well as checking the carbon dioxide level of that blood exiting the heart. And how cool is it that we have these sensors that are automatically checking the oxygen level and the carbon dioxide level of the blood that is going directly to our brain by way of the carotid arteries. So these receptors are very strategically located, and they send feedback loops. They send the stimuli directly to those respiratory centers, influencing the rate of our respirations. But not just the oxygen level and the carbon dioxide level, but also the overall pH. In other words, the hydrogen ion concentration. So the peripheral and the central chemoreceptors are also sensitive to the overall pH of our blood and cerebrospinal fluid. If you recall, the pH of our blood has to be in between 7.35 to 7.45. It is slightly alkali, slightly on the alkali side. Remember, the pH of 7.0 is neutral. So what happens? Well, if the hydrogen ion concentration increases, in other words, the fluid becomes more acidic. The chemoreceptors stimulate the respiratory centers to speed up. The hydrogen ion concentration is heavily influenced by the carbon dioxide concentration and the sodium bicarbonate concentration in blood and cerebrospinal fluid. So what that tells you is, or what that bullet tells you is, that carbon dioxide can be thought of as an acid. And this becomes important when you guys start learning about ABGs, or arterial blood gases, in med-surg nursing. So not just the hydrogen ion concentration or the pH, but also the overall stretch. Now, there are stretch receptors within our lungs and our chest wall that constantly monitor the amount of stretch. So what happens? Well, if the lungs become overinflated, in other words, if they stretch too much, they signal the respiratory centers to exhale and inhibit inspiration. So these stretch receptors kind of work as a protective mechanism. And then, of course, we have those higher brain centers, because we did say even though respirations are occurring automatically by way of our autonomic nervous system, we still can, however, consciously override it. We still can, however, consciously influence them. So we've got nerve cells within the hypothalamus and within the cortex that can also influence the activity of our respiratory center. So we can choose to hyperventilate, or we can choose to, for example, hold our breath. Now, for example, during pain or strong emotions, the respiratory centers will speed up. And this is why when you are experiencing a very emotionally strong response, like crying or anxiety or pain, this influences your overall respiratory rate. Even the voluntary control measures by the cortex can stimulate the respiratory centers to speed up, to slow down, or to even stop, like when we're holding our breath. So we can choose to hyperventilate, we can choose to hypoventilate, and we can choose to become totally apneic, totally hold our breath. But the influence, however, can be overridden, as we mentioned, by chemical factors, meaning the oxygen level, the carbon dioxide level, as well as the pH. Other things that can influence the respiratory centers, chemical irritants like nerve cells within the airways can sense the presence of unwanted substances such as pollen or dust or noxious fumes or water or cigarette smoke. If you guys recall the case study that we did in class, one of the case studies was with the weekend warrior, the jogger that collapsed in the park adjacent to that industrial area. So chemical irritants can play a role and influence the respiratory centers. So we have cells that then signal the respiratory centers to contract respiratory muscles, causing you to, for example, sneeze or to cough. Remember, we did say that there's only one way in and one way out. And on top of that, the air that we breathe in is not sterile. It's filled with tons of crap, like pollen and dust and noxious fumes, water or cigarette smoke. Coughing and sneezing actually cause air to be rather rapidly and violently exhaled from our lungs and from our airways, removing whatever that offending substance was. Now, out of all of these factors that we talked about, out of all of these factors, and we talked about the oxygen level, we talked about carbon dioxide, we talked about pH, we talked about irritants, out of all of these factors, by far the strongest influence that we have for respirations is the carbon dioxide concentration within our blood and cerebrospinal fluid. That is followed by the oxygen concentration. So what I'm trying to tell you is that for normal, healthy individuals, the primary stimulus to breathe is the carbon dioxide level within our blood and our cerebrospinal fluid, followed by the backup mechanism, which is the oxygen concentration within our bloodstream. So the primary stimulus to breathe is our carbon dioxide level, not our oxygen level. This becomes important when we have a disease process known as COPD. With these individuals, their primary stimulus to breathe winds up being the backup mechanism, which is oxygen. But remember, for normal, healthy individuals, the primary stimulus to breathe is our carbon dioxide levels, not our oxygen level. The oxygen level is the backup mechanism. Now, sometimes the respiratory centers can go temporarily crazy. They can go temporarily array and wind up sending extra impulses to the diaphragm. And these impulses can cause unwanted contractions, like, for example, hiccups. And one of the things that's kind of interesting to note is that younger individuals, so kids, for example, toddlers, school-aged kids, they have a higher incidences of things like hiccups than do older individuals. So when you do see things like hiccups occurring, or on a more than regular or frequent basis in individuals, usually it's a sign of an underlying pathology that's occurring either with the respiratory system or with the GI system. Okay, so now since we've talked a lot or at great detail about the things that can influence our respirations, things that can be microscopic or chemical in nature, leading all the way up to the tissue or the organ level or even the anatomical level. There are a huge amount of factors that can influence our overall respirations. So when our lungs begin to fail, here we're talking about diseases or conditions of the lungs, which really can be mainly broken up into two types. Those that can make breathing harder, so those disease processes or those pathophysiological states that influence the mechanics of breathing, and those disease processes that can damage the lungs' ability to exchange carbon dioxide for oxygen. So no matter what the disease is, no matter what the issue is, no matter what the pathophysiological state is that we're talking about with our respiratory system, it can really fall within one of these two categories. Those that influence the mechanics of breathing, in other words, making breathing harder, and those that influence the lungs' ability to exchange carbon dioxide for oxygen. So influence at the chemical level for our lungs. Now, just something very interesting, which is that our lungs are second only to our skin in the degree to which they come into contact with the external environment. Because remember, the air that we breathe in is not sterile. So our lungs on the inside, our respiratory tree, is coming into contact with the external environment. In other words, with the air that we breathe in. So the potential for invasion and infection is very, very high. Now, what I mean by that, and why I have a picture of Serena Williams on that slide, is that if we were to take all of our alveoli, all of those tiny grape-like sacs, and if you were to cut them in half and take like a rolling pin and were to roll them out and flatten them and put them all edge to edge, that surface area would be about the size of a tennis ball court. Now, I've said this to you guys before, and I'll say it to you guys again. You don't need to be a rocket scientist to figure this stuff out. If you have something within your body that's the size of a tennis ball court, it has an important function. So once again, if you were to take all the alveoli that you have within your lungs, all of the alveoli, cut them in half, and flatten them using a rolling pin. All of those alveoli, that surface area where gas exchange takes place, is about the size of a tennis ball court. That is how important their role is within our bodies. So the lower respiratory tract can be exposed to pathogens by inhalation, so we can simply breathe them in. Remember, we mentioned that the air that we breathe in is not sterile. Look at how we are breathing in this COVID-19 virus, and immediately it winds up attacking our lungs. Aspiration. So we can, for example, aspirate gastric contents, and then it can dump into our trachea. So remember, we did say that within our respiratory system, there's only one way in and one way out. So if we don't have a very robust coughing reflex, then we can't bring out the contents that we just aspirated. And then now we have a warm, moist, dark, nutritive environment, a perfect environment for bacteria to work on that aspirated contents, giving forth pneumonia. And this is one of the reasons why in the hospital setting, we always worry about the patient's gag reflex and effective swallowing, because we don't want that patient aspirating. Because if they don't have a robust cough reflex, then you have to suction that contents out of their respiratory tree. Now, the lower respiratory tract can be exposed to pathogens by vascular dissemination, and what that simply means is it's just a fancy way of saying that there is a disease process or an infectious process that's occurring somewhere else in the body, like a lower extremity diabetic wound, and now that infection has not just that infection has traveled more than just locally and has now traveled systemically and has now taken residence in the lungs, as well as exposed to pathogens by direct contact with contaminated equipment like suction catheters. There's a reason why within the acute care setting, suctioning of the respiratory tract is sterile. So you're constantly using a sterile setup, sterile gloves, sterile water, sterile suction catheter each time you suction an individual. In the home care setting, suction doesn't have to be sterile. Suction can be done using clean technique. And the reason for that is because the contaminants and pathogens and, you know, metabolites that we find within the home care setting are not as virulent as what we see within the acute care setting. So that's why in the hospital setting, in the acute care setting, suctioning of the respiratory system has to be done as a sterile technique. And this is actually a popular question that's asked on the NCLEX, because they want to make sure that you know the difference between why you're suctioning sterilely in the acute care setting and why you're suctioning clean technique in the home care setting. So diseases or conditions that can influence the mechanics of breathing include diseases such as asthma, where we have bronchioles which constrict, reducing the size of the airway so they become very, very narrowed. It cuts down on the overall flow of air, making respiratory muscles work harder. Another disease process known as emphysema, where we have lungs which begin to stiffen with fibers and becoming less elastic. Remember, we said in the very beginning that our lung tissue is a very elastic tissue. When we stretch it out, it naturally comes back to its original shape and form. We don't have to force it back. It naturally just elastically recoils back. But with emphysema, the lungs become less elastic, so we wind up having to squeeze them to get them back to their original shape and form. This thereby increases the overall work of the respiratory muscles. the muscles that we know of as our intercostal muscles, the external intercostal muscles, the internal intercostal muscles, as well as the diaphragm. And then, of course, bronchitis, where we have the airways becoming inflamed and narrow, thereby restricting the flow of air while also increasing the overall work of these respiratory muscles again. Now, asthma, emphysema, and bronchitis, they form this triad that we know of as COPD, otherwise known as chronic obstructive pulmonary disease. And towards the end of this lecture, we will be talking more about that. But another disease or condition is known as pneumothorax that winds up influencing the mechanics of breathing, where we wind up having the equalization of pressure within the chest cavity and the outside air. Remember we said, using that water bottle example, that there's only one way in and one way out, and when we squeeze from the outside, it causes an increase in the pressure on the inside of the water bottle. And if we were to pull apart the walls of the water bottle from the outside, that leads to a decrease in the air pressure within the water bottle. Well, when we have a pneumothorax, now we have more than just one way in and one way out. This causes the lungs to collapse. And it can be usually due to like trauma, like a gunshot wound or a stab wound, or even an injury, like when we have one of our ribs can pierce our lung during, CPR compressions. So it can be due to any type of trauma. But what happens is that there is an equalization of pressure within the chest cavity and the outside air. So it once again winds up influencing the mechanics of breathing. And then last but not least, that example of apnea, where breathing winds up slowing down or even stopping altogether. And this can happen under a variety of conditions. There's many types of different apneas, like, sleep apnea, obstructive sleep apnea, and there are usually caused by problems within the respiratory centers. But once again, it winds up influencing the mechanics of breathing. So the previous slide dealt with those diseases that influence the mechanics of breathing. This slide lists certain diseases or conditions that minimize the overall or prevent the overall gas exchange from occurring, the carbon dioxide for oxygen. The first example is pulmonary edema. And within pulmonary edema, what winds up happening is fluid begins to build up between the alveolus and the pulmonary capillary bed. So if we can recall that animation that we saw several slides ago, where we saw the alveolar air sac adjacent to the pulmonary capillary bed, and we saw the oxygen move from the alveolar air sac into the pulmonary capillary bed, and we saw the animation of the carbon dioxide leaving the pulmonary capillary bed and entering into the alveolar air sac. Well, we saw how close they were together, and I made a special point of recognizing the close proximity of the capillary bed to the alveolar air sac. Now, if you can remember the close proximity of those cells, and I said, well, diffusion takes place very readily because the cell layer or the wall layer is only about 1 or 2 cell layers thick. Now imagine if we were to have fluid in between the pulmonary capillary bed and the alveolar air sac, pushing them further apart. So now the gas, whether it be oxygen or carbon dioxide, now not only has to diffuse across the cell membrane, but now it also has to diffuse across fluid, and that takes much longer. So this increases the distance over which the gas exchange takes place, thereby slowing down that exchange. So this is something that happens in a disease process that maybe you've heard of, known as congestive heart failure. When someone winds up with pulmonary edema, they wind up with fluid within their lungs. All that fluid winds up pushing the distance between the pulmonary capillary bed and the alveolar air sac further apart. So as we mentioned, now the oxygen has to diffuse across not only the cell, but also fluid, and it takes much, much longer. Same thing with the carbon dioxide. The next disease or condition is smoke inhalation. And this is when we have smoke particles which wind up coating the alveoli, and it winds up preventing the exchange of gases from taking place. And this is how most people die, like for example in fires. People don't die because they wind up being burned to death. People die in fires because the smoke that is being generated as a result of things being on fire, and we breathe in that smoke coats the alveolar membrane, so it prevents gas exchange from taking place. That's how most people die, as a result of asphyxiation because of smoke inhalation. The next disease or condition is carbon monoxide poisoning. Now, carbon monoxide, and if you take a look, it just is CO as opposed to CO2, which is carbon dioxide. Carbon monoxide, CO, binds to hemoglobin much more tightly than either oxygen or carbon dioxide. In fact, once carbon monoxide occupies that little spot on the red blood cell, it doesn't want to give it up. So this diminishes the delivery of oxygen to all the target tissues of the body, namely your brain, your heart, your muscles, and it's a very common product of very poorly ventilated heaters, like space heaters, and of automobile exhausts. And the condition is fatal if it's not caught soon after exposure. And this is one of the reasons why there's this huge push that if you have like a gas heater at home, or if you have a gas stove or a gas range or a gas water heater or a gas boiler, that you really have carbon monoxide detectors within your house or within your apartment, because carbon monoxide is an odorless and it is an invisible gas. And once it takes that place on the hemoglobin molecule on the red blood cell, it doesn't want to give up that spot. So it's one less spot that oxygen can bind to. So this is what winds up killing individuals, carbon monoxide poisoning. So first disease state that we're going to acknowledge is acute bronchitis. And this is where we have inflammation of the bronchial tubes leading into our lungs. It usually develops rapidly and can last fewer than 2 to 3 weeks. In a small percentage of people, acute bronchitis can return and become long-lasting, and this shouldn't be confused with chronic bronchitis. Chronic bronchitis is a separate disease process which falls into the category of COPD, which we will talk about several slides coming up. But this acute bronchitis is a different treatment plan than chronic bronchitis. Now, older adults are usually, more susceptible to things like acute bronchitis. And what I want to bring your attention to is that this is what the diameter of a normal bronchus looks like. Nice, clear, wide open, plenty of room for air to go in and out of that respiratory passageway. But this is the lumen of an airway or a bronchiole that is now inflamed as a result of acute bronchitis. So you can see, as a result of the inflammatory process, the itis or the itis suffix in acute bronchitis, when we're talking about inflammation, this greatly reduces the overall diameter of the passageway and thereby allowing less air to be moved into and out of the alveolar air sac. Now, it usually is caused by a virus. It's much more common during winter months, and it often develops after an upper respiratory illness such as influenza or the flu. colds caused by a virus such as coronavirus, something that we're, dealing with right now, the COVID-19, adenovirus or a rhinovirus, RSV or respiratory syncytial virus in older adults, as well as even in kids. And acute bronchitis is caused by bacteria really only about 10% of the time. And 90% of the time it's caused by a virus. And this is one of the reasons why this COVID-19, this outbreak is of such paramount concern, because it winds up influencing your respirations. And remember, I mentioned to you guys that you can perform any nursing intervention in the world, but if the patient doesn't have a patent airway, that nursing intervention is not going to do a damn thing. In fact, respirations are so important that they literally are two of the big three. In other words, the ABCs, the airway, the breathing, the circulation. Respirations comprise two of those three important critical attributes. So this is why there is such a huge a concern regarding the coronavirus and this COVID-19, this novel coronavirus, because not only has our immune systems never seen this before, but also because it winds up influencing the respiratory system. Now, acute bronchitis can also be caused by exposure to, for example, our external environment, exposure to smoke, chemicals, air pollution, accidentally inhaling, otherwise aspirating food, vomiting or mucus material. Any one of those things can trigger acute bronchitis. Remember, as I mentioned to you before, the air that we breathe in is not sterile. It's filled with tons of crap. It's filled with tons of dust and pollen and who knows, asbestos, and it is then lining the internal respiratory tree, and it's triggering an inflammatory process, and it may trigger acute bronchitis. That's why we have these cilia that line our respiratory tree, and what that cilia does, as well as the mucus blanket that we have within our respiratory tree, it helps to trap all of these potential contaminants that we find within the air. So the mucus blanket helps to trap all that pollen and all that dust, and the cilia help to brush up and out, up towards our throat, so that we can cough up and out all that debris that we inhaled in. Because once again, the air that we breathe in is not sterile. You can almost think of that cilia as a respiratory escalator. It is brushing and it is combing that mucus blanket, and it is bringing all that debris up to our throat so that we can cough it up and out. Very similar to like an escalator, bringing all those contaminants up. Now, what are the symptoms of acute bronchitis? Well, common signs and symptoms of acute bronchitis include a cough, which could be clear, yellow, or green mucus, mild fever, usually less than 101, generalized malaise, dyspnea, respiratory wheeze. Symptoms can usually begin 3 to 4 days after an upper respiratory infection, like a cold or the flu, and this is one of the reasons why people are having such a hard time being able to distinguish people who have seasonal allergies or acute bronchitis or COPD versus COVID-19 positive. And that's why there's such a huge push for COVID-19 testing, so that once you establish if you're positive or negative, then you can go into quarantine, because this virus, this novel virus, is that virulent. It is that aggressive. Now, the next disease state is pneumonia, where we have an inflammation of the lung parenchyma, most often caused by infection with a bacterium, a virus, a fungus, or a protozoan. It causes difficulty breathing and ultimately can affect gas exchange at the alveolar level. And symptoms often begin suddenly and may follow an upper respiratory infection such as influenza, like the flu, or a common cold. And this is what unfortunately the coronavirus, this novel COVID-19 virus, winds up doing. It winds up initiating pneumonia in individuals. Now, there's different classifications of pneumonia. For our purposes, we just need to basically recognize the primary and secondary classifications. Primary meaning direct, where we have an inhalation or aspiration of a pathogen like a bacteria, a virus, or we can have secondary, which is indirect, where we have lung damage from a noxious chemical or hematogenous spread of bacteria or aspiration of foreign matter. But the main thing is that it winds up impacting the overall exchange for oxygen within our lungs. Here you can see the internal view of one's respiratory tree and the secretions that one can find. This is pneumonia caused by a fungal infection. Because remember, we did say that there's many, many different types of pneumonias. Now, some signs and symptoms include fever. It can be low grade or it can be a full-blown fever up to 106 degrees. Shaking chills, a cough that often produces colored mucus or sputum from our lungs. It can be rust-colored or green or blood-tinged. Older adults may have a slight cough with maybe no sputum production at all, so it might just be a moist non-productive cough, hyperpneas, chest wall pain, often made worse by coughing or deep breathing. Sometimes these individuals will say that when they cough, they feel the pins and needles feeling on the inside when they cough, as well as fatigue and feelings of weakness, generalized malaise. With bacterial pneumonia, we have alveolar inflammation and edema, which wind up being triggered. Alveolar capillaries wind up being engorged with blood, causing stasis and then ultimately breakdown of those alveolar membranes. The alveoli wind up filling with blood and exudate, resulting in atelectasis or alveolar collapse. Now remember, we are counting on that entire tennis ball court surface area. But when atelectasis occurs and the alveoli winds up collapsing, we don't have that entire tennis ball surface area anymore for gas exchange to take place. This bacterial pneumonia is treated with antibiotics, and other medications or treatments may also be necessary, like nebulizer treatments or inhalation treatments. Bacterial pneumonia winds up being the leading cause of death in debilitated patients. And this is one of the things that when people get admitted into the hospital setting, when the nurse is doing their admissions assessment, one of the questions that the nurse asks as part of the admissions process is that, have you ever had the pneumonia vaccine? Especially, have you ever had the pneumonia vaccine like within the last 5 years? Because pneumonia is one of those disease processes that can wind up happening nosocomially in the acute care setting. So they always try to encourage, if not, mandate the pneumonia vaccine upon admission, especially if you haven't had it within the last 5 years. So the alveoli wind up filling with blood and exudate, resulting in atelectasis or alveolar collapse. And some of the causative organisms for pneumonia or bacterial pneumonia include streptococcus or strep, Klebsiella, staph infections, as well as the pneumococcus bacterium itself. We can also wind up having viral pneumonia. And what winds up happening is that the virus attacks the bronchiolar epithelial cells, bronchial mucus glands, as well as goblet cells, causing interstitial inflammation as well as desquamation. So an eroding away of those different layers. It then winds up invading the alveoli, resulting in blood and, once again, exudate accumulation. So you wind up losing that full tennis ball court surface area that you once had, resulting in a decreased amount of surface area where gas exchange can take place. Now, symptoms of viral pneumonia are often less severe than that of bacterial pneumonia, and they even may come on more slowly. If you've ever heard that term called walking pneumonia is a slang or layman's term for viral pneumonia because it's oftentimes not even detected. The person may not even appear that very ill at all. Symptoms can, of course, vary with one's age and other underlying health problems, and this is one of the things that is being triggered with these individuals who are COVID-19 positive. It's triggering a viral pneumonia, but depending upon if you have underlying disease processes like cancer or diabetes or high blood pressure or obesity or a compromised immune system, if you have one of these underlying disease processes, then that puts you into a higher risk category, especially with increased age. And this is what's making this COVID-19 so deadly. And this is why they have very, very few incidences of mortality with younger individuals, like below 30, especially teenage, as well as, with school-age children or even infants or babies themselves. There have been, unfortunately, fatalities, but they have been lower than 1%. The majority of them have been all with individuals that are above 60 years old. Causative viral agents, of course, including influenza, adenovirus, coronavirus definitely, respiratory syncytial virus or RSV, rubeola, varicella pneumonia, as well as cytomegalovirus, all have the potential to trigger viral pneumonia. Now, hospital-acquired pneumonia, as we mentioned, pneumonia that is acquired in the hospital is a very serious infection. Oftentimes, the patient's defense mechanisms are often impaired by illness. That's why they're in the hospital to begin with. And then the infecting organisms that we find within the acute care setting, those infecting organisms are usually much more dangerous and much more virulent than what we find within the regular community. And this is one of the reasons why they tell you that the worst place to be when you're sick is in the hospital. Because when you're sick, your immune system is down, and the organisms that we find within the acute care setting, within the hospital setting, are much more virulent. So that's why they cause so much disease process, and that's why there is such a push to have you discharged as quickly as possible. Now, aspiration pneumonia is also of specific concern. And here with aspiration pneumonia, this usually is as a result of inhalation of food particles. So the food goes down the wrong tube and goes down your trachea instead of your esophagus. It could be the inhalation of gastric juices due to vomiting or due to aspiration, as well as the inhalation of toxic chemicals like hydrocarbons. So it triggers an inflammatory change and it winds up inactivating surfactant. Now, if you recall from when you guys took anatomy and physiology, you learned about surfactant as being important, allowing the alveoli to maintain their natural round grape-like shape. We have to remember that within our lungs, deep, deep, deep within our lungs, in our alveoli, it's a very moist environment. It's not exactly wet, but it's moist. And those of you guys that have kids, you know of these specific decals that you can use to put on your bathroom or your shower or your tub walls when you're bathing your child. These animated little vinyl stickers can stick up on the wall with just water without any adhesive at all. And the water is enough to keep these stickers on the walls of your tub while you're giving your child a bath. So that tells you the force or the attraction that water particles have for one another. So when we look at a moist environment like our alveoli, the natural tendency is for the alveoli to collapse because the water is attracting the other water molecule, causing the collapsing of that alveolar air sac. Surfactant winds up inactivating that process. So surfactant allows for the alveoli to maintain their robust, round, balloon-like, grape-like shape so that they don't collapse, so that we have the full basketball court, or excuse me, the full tennis ball court for gas exchange to take place. There's also something called pneumocystic carny pneumonia, or PCP pneumonia, which was the most common life-threatening infection of the AIDS epidemic, or the AIDS patients within the US. And in fact, back in the day, before they had all these fancy tests for finding out if somebody had the HIV or if they were HIV positive, now there's just a rapid swab within 15 minutes. You know if a patient is HIV positive or not. But back in the day when we didn't have those fancy tests, and it took a very, very long time, when we had patients who developed this pneumocystic carny pneumonia, uh, it was a safe bet that they also were HIV positive. So it wound up being the AIDS defining illness in about 60%, which is a huge percentage of patients during the 80s. Now, without prophylaxis, greater than 80% of AIDS patients would have developed one or more episodes during their illnesses. So this was one of the things that the AIDS patient had to be also treated for, this PCP pneumonia, that our immune systems in normal healthy individuals winds up taking care of automatically. So just to quickly summarize so that we can put a cap on pneumonia. Pneumonia really is it's a generic term for any condition that can result in the filling of the alveoli with fluid. Now, although chemicals and many microbes can all cause pneumonia, a very common cause is the pneumococcus bacterium itself. And this is the vaccine that one gets when, or one is offered when they get admitted into the hospital, the pneumococcus or the pneumonia vaccine. So therefore, the very old or the very young or individuals weakened by illness or have weakened immune system are the ones that are more susceptible. Okay, the next pathophysiology process that we need to discuss is tuberculosis, very commonly referred to as just TB by the acronym. TB is a bacterial infection affecting one's lungs. In that case, it is called pulmonary TB. However, it does not have to be limited just to one's respiratory system. It can also affect other parts of the body as well. In that case, it is referred to as extrapulmonary TB. But 90% of the time, or greater than 90% of the time, we find tuberculosis localized to one's respiratory system. It's characterized by these white lesions, or what's referred to as tubercles or cavitations, and that's how the disease process actually gets its name, by these white lesions or these white tubercles, which can be observed on a chest x-ray. And these tubercles replace the normal alveoli where gas exchange takes place with now scar tissue. Now, in scar tissue, it's very difficult for this gas exchange to take place. This results in poor gas exchange between the pulmonary capillaries and the alveolar air sac. Now, the symptoms include, of course, coughing and sputum production, as well as generalized malaise or lethargy, as well as dyspnea or shortness of breath. And TB can be classified as either latent or active TB. If you take a look at this chest x-ray here, and one of the things that you will see within your careers, when you look at a typical normal chest x-ray, what you want to see are nice, clear, black lung fields. And because the picture of what you're taking is just air, what we expect to find in our thoracic cavity should just be air. However, anytime we experience, these white, cloudy, hazy type areas like what I circled there in front of you, this white lesion, then that's the red flag that goes up that says, well, wait a second, something is wrong. There's an area of density there that shouldn't be there. It should be nice, clear, black lung field. And oftentimes these tubercles or these white lesions appear on the upper thirds of the lungs. So if you were to auscultate on your patient their lung fields, in that area you would not hear very robust lung sounds. Now, with latent TB, what has happened here is that the immune system has detected the bacterium within the lungs and it has walled off or encapsulated that bacterium into those tiny tubercles. And that is what you just visualized on the chest x-ray on the slide before. Now, however, the bacteria is within the body because the immune system has walled it off. The individual cannot spread the infection to others. However, there is a risk for developing TB or active TB if their immune system becomes weakened. Now, when we talked about the inflammatory and the immune response, I mentioned to you guys that there is no rule book anywhere that says that our bodies can only be fighting off one infection at one time. So if our immune system, let's say, for example, is actively working, fighting off a disease process and is distracted, or if our immune system is immunocompromised for whatever reason, let's say, for example, because of chemotherapy treatment or radiation therapy treatment, or because of steroid therapy treatment, well, then there is a risk for developing active TB if their immune system becomes weakened. Now, when someone has active TB, the infection is spreading in the body and it also can be transmitted to others. Now, if you recall, TB is airborne. So here, with airborne precautions, the TB causing bacterium is so lightweight that it can actually travel on air currents for a very long period of time. Now, these individuals who have TB, they have to be put in a special air negative pressure room to make sure that there are no bacterium that can ride on air currents that can exit out of that room. They have to be within a special negative pressure room. So what causes TB? Well, the TB is caused by the Mycobacterium tuberculosis. And since you guys have taken microbiology, you guys can better appreciate this as it's a slow-growing bacterium that winds up thriving in areas of the body which are rich in blood and oxygen supply. And the perfect area happens to be our lungs. So the symptoms that we see if someone has latent TB, they won't have any active symptoms. They won't have symptoms unless the disease becomes active. Now, some of the symptoms that one might see would include a persistent cough, oftentimes with thick, cloudy, and sometimes bloody mucus or sputum. Oftentimes the patient will complain of generalized fatigue as well as weight loss. But what seems to be the distinguishing factor happens to be night sweats with fever. So oftentimes the patient will complain saying that, you know what, I wake up in the middle of the night because I'm drenched and my shirt is soaked. My pajama shirt is soaked. And I know that it's not my blood sugar because I'm not diabetic. Or if they happen to be diabetic, they check their blood sugar and their blood sugar is normal. So what winds up happening is that there is this key sign and symptom of night sweats accompanied with fever, usually during the night when the person is sleeping, that they wind up waking up from. Along with that, we also have shortness of breath and chest pain with inspiration, as well as tachycardia as well. Now, people who have latent TB cannot spread the disease. Remember, their immune system has walled off the TB causing bacterium in a tubercle, and that is what one visualizes on a chest x-ray. Pulmonary TB, remember, is very contagious, and it spreads when a person who has active disease exhales air containing the TB causing bacterium, and another person inhales that same air. Now, extrapulmonary TB, on the other hand, does not spread very easily to others at all. So latent TB is detected with a positive reaction to a tuberculin skin test, or otherwise known as a PPT, which is what all of you guys got before the starting of the nursing program, in which you had a intradermal injection of 0.1 ml solution given 15 degrees with the needle bevel up right underneath the surface of the skin, and there was a little bump or a little wheal that was made as a result of injecting that solution. And what the provider did was they circled that area, and you had to come back at a later time, usually within 48 hours to about 72 hours within that window, to have the PPD read. And what the provider is looking for is something called an induration. That's the term that the NCLEX likes to test, the term induration. And if you have a positive reaction, that doesn't mean that you have TB. What that means is that somewhere along the lines, somewhere along the way, you came into contact with the TB causing organism. Now, there is a high degree of false positives with these PPD tests. In fact, a lot of areas around the world, a lot of countries that inoculate their population for the TB organism. In other words, they vaccinate their population against TB with something called a BCG. These individuals wind up with a positive reaction to these tuberculin skin tests. Now, active TB is diagnosed by actually finding the TB causing bacterium in a sputum culture. So if you have a patient that gets admitted and they are admitted on your floor for rule out TB, well, they would be hooked up in the patient or in the negative pressure room, and only the individuals who would need to go into that room to administer care to the patient would wear the N95 particulate respirator mask. Otherwise, the patient in the room, in the negative pressure room, doesn't need to wear a mask at all. Okay, so the active TB is diagnosed by this sputum culture known as sputum for AFB, which stands for acid fast bacilli. And there is a sputum culture that is done every morning for 3 mornings. And if any one of those are positive, then the treatment plan is the antibiotic therapy for tuberculosis. If all 3 sputum cultures for 3 days straight come back negative, then the patient can be taken off airborne precautions and be taken out of the negative pressure room. A chest x-ray can also be used to help diagnose active TB, and extrapulmonary TB is usually diagnosed by not only a biopsy, but also a culture and diagnostic imaging like CAT scans or an MRI. Now, TB is treated with long-term antibiotic therapy and usually combinations of therapies which are used to treat active TB, and whether it occurs in the lungs or elsewhere. Now, medications for active TB must be taken for a minimum of at least 4 to 6 months. And there's a high percentage of affected patients who take their medications as prescribed, which become cured. Latent TB usually is treated with antibiotic therapy, oftentimes for anywhere from 6 to 9 months. And this helps to prevent infection from developing into active TB disease and reduces the risk of associated complications. Now, whether you have active or latent TB, the treatment plan is going to be antibiotic therapy, and oftentimes for a very long period of time, as you can see here, for several months. And it's very important that the patient remain compliant when it comes to their medication therapy. That is absolutely critical. So if the patient winds up forgetting their medications, let's say, if they were, for example, had Alzheimer's or the beginning stages of Alzheimer's disease, and they would be non-compliant and forgetful with their medications. Well, if the patient misses a period of about 24 hours where they did not take their anti-TB antibiotics, well, they would have to start the treatment plan all over again as if it was day one. So this winds up being of paramount concern, which is the compliance factor for antibiotic therapy. Here you can see the estimated TB incidence rates in the early 2012 area. You can see here that it really doesn't affect North America as much as it does the rest of the world. But unfortunately, the thing is that the TB causing bacterium is so pervasive, it is so virulent that it can spread like wildfire in a non-vaccinated community, such as, for example, the US. So active containment right away is very, very important, such as, what we're experiencing now with the COVID-19 coronavirus. That's why there's such a huge push to find out who are those individuals that are testing positive, because once you have a positive, then you can actively contain it. So that's why there's a huge push to find out and to diagnose and to test. The next disease state that we're going to talk about is COPD, or chronic obstructive pulmonary disease. And I'm going to ask you guys to recall an important fact that I mentioned a little bit earlier, which was that the stimulus to breathe for us happens to be our carbon dioxide levels. The backup mechanism happens to be our oxygen levels. So with these individuals who have COPD, their stimulus to breathe winds up being the backup mechanism, which is the oxygen level, and we will see why. But COPD is a condition making it difficult to breathe due to air not flowing easily out of the lungs. Now, these individuals definitely have a problem getting air into the lungs, no question about that, but they have more of a difficult time getting air out of the lungs. In fact, the lungs kind of lose their elasticity. They become stiffened, in which the body has to resort to using the intercostal muscles and the diaphragm to squeeze the air out of the lungs out so that it can escape out of the thoracic cavity. And we did say, remember, that there's only one way in and one way out. Now, the three most common long-term chronic problems causing permanent airflow problems are chronic bronchitis, emphysema, and asthma. Now, COPD may include a various form of these conditions. Although a person may have one of the three conditions, most people usually have a combination of all three conditions. So here you can see a diagram that's showing that there's overlap that's occurring within emphysema and chronic bronchitis as well as asthma. Remember, this chronic bronchitis is different from the acute bronchitis that we discussed several slides ago. So COPD, and as the name kind of implies, chronic, meaning that it is occurring over a very long period of time, oftentimes years, if not decades. Obstructive, which means that yes, the patient has a difficult time getting air in, no question about that. However, they have a more difficult time getting air out. Pulmonary disease or respiratory disease. Now, one thing that I want you guys to kind of envision is that if it is taking longer for air to get out of the lungs, exchange is still taking place. In other words, the exchange for carbon dioxide and the exchange for oxygen is still occurring. So if we're holding on to air longer because it's taking longer to squeeze the thoracic cavity to get air forcibly out of our lungs, exchange is still going on. So what is occurring over time is that these individuals have higher levels of carbon dioxide because it's taking them longer to get air out of the lungs. All right? Remember, the air that we're exhaling is higher in carbon dioxide, lower in oxygen. The air that we breathe in is higher in oxygen and lower in carbon dioxide. So if it's taking longer for us to get that air out, that means that we're holding on to this carbon dioxide rich air longer, which means that carbon dioxide is affecting our body cells greater over a period of time. And as the name implies, chronic, oftentimes these individuals learn to live with higher levels of carbon dioxide within their bodies for years, if not decades. So what that means is, if you will recall that the stimulus to breathe in normal, healthy individuals is their carbon dioxide levels, with these people who have COPD, because the body learns to live with higher levels of carbon dioxide over longer periods of time, oftentimes many, many years, if not decades, well, that those sensors that detect carbon dioxide get blunted and blunted and blunted and blunted over time, that for these individuals, the stimulus to breathe no longer is the carbon dioxide level. It winds up being the backup mechanism, which is oxygen. Now, this becomes important as we continue. Now, with COPD, chronic bronchitis and emphysema are most often caused by long-term cigarette smoking, and over time, COPD worsens and winds up leading to severe difficulty breathing, as well as cardiac pathology. Things like maybe you've heard of something called atrial fibrillation, as well as death as a result of cardiac abnormalities. Here, if you take a look at the animation, you can see the normal passageways leading to the alveolar air sacs, and you can see the expansion and the contraction elastically of these normal airways. But when we have bronchitis or when we have emphysema, we lose the overall robust expansion of the alveolar sacs, and therefore it impacts our gas exchange. With emphysema, you can see that there is a smoothing out of the alveolar air sacs. So what this is telling you is that we no longer have that huge surface area of a tennis ball court anymore. We wind up losing our surface area of the tennis ball court. So there's still exchange taking place. However, it is nowhere near the size that we once had. So with emphysema, the alveoli in the lungs are damaged, usually, as I mentioned, as a result of long-term cigarette smoking. Once this damage has occurred, it cannot, unfortunately, be repaired. Emphysema is a form of COPD that winds up causing dyspnea and shortness of breath that winds up getting worse over time. So here you can see the normal lung tissue on the left-hand side with normal alveolar air sacs in those grape-like clusters, plenty of surface area for gas exchange to take place. We've got that full tennis ball court, and then we can see on the right-hand side the damaged lung tissue as a result of emphysema. So we see a flattening out of those grape-like air sacs, which winds up depleting more surface area where gas exchange can take place. Here we can see once again an enlarged view of the air sacs known as alveoli. On the bottom part of the picture, you can see what nice, normal, healthy air sacs should look like. And on the top part of the picture, you can see the air sacs as a result of emphysema. So we have weakened and collapsed air sacs with excess mucus production, and that winds up impacting the overall exchange of carbon dioxide and oxygen. Now, chronic bronchitis is presented, and this is actually how it winds up being diagnosed. Chronic bronchitis is present when a persistent cough occasionally brings up excessive mucus from the lungs for most days of a 3-month period in at least 2 years in a row. This is some of the, believe it or not, diagnostic criteria for chronic bronchitis. Now, chronic bronchitis is a result of, once again, smoke or other environmental pollutants, resulting in a hypersecretion of mucus as well as inflammation. So once again, we see a disease process that's impacting the overall surface area where gas exchange takes place. Here we can see on the left side of the screen a normal bronchiole, and you can see the size of the lumen, which is huge. So there is plenty of area for air to move in and out very readily. If we take a look at the lumen on the right-hand side of an bronchi that has or that is suffering with bronchitis, you can see the impact on the overall luminal diameter, and you can see a huge decrease in the amount of air that can travel through that bronchiole. And last but not least, asthma. Now, asthma is a chronic disease of the respiratory system causing diffuse airway inflammation, a hyperresponsiveness, if you will, as well as mucosal edema and mucus production. Now, the inflammation causes episodes of difficulty breathing, like, for example, what you may hear as evidenced by wheezing. And sometimes you don't even need a stethoscope to listen to someone when they're breathing and hearing a respiratory wheeze. Sometimes, like let's say, for example, when a person is in a very warm classroom and then they go outside and it's very cold outside, the temperature outside, you can hear them wheeze without even a stethoscope. Sometimes the inflammation can cause episodes of tightness within the chest, or the person might experience coughs, and these episodes are called asthmatic attacks. Now, if you take a look at the pictures that you see here, for someone on the left-hand side, we can see a normal bronchiole, and you can see the overall diameter of the inner lumen, and there is plenty of room for air to move freely in and out of the bronchiole. But if you take a look on the right-hand side, you can see clearly the inflammation that's taking place. That's not only decreasing the luminal size, but there's also mucus that's being produced in the center of that lumen. So it is also impacting the overall amount of air that can wind up leading into the alveoli. So most people can control their asthma by following a plan that they develop and by taking certain medications. You know, there are the maintenance medications, and then there are the rescue medications. Like, you know, there is the rescue inhaler and then there's the maintenance inhaler. So asthma is treated by avoiding irritants and allergens such as things like pollen and dust and smoke. Sometimes even exercise can trigger an asthmatic attack, cold air, stress, all of which can trigger asthmatic attacks. And medications to control the inflammation as well as to reduce the overall number and the severity of asthmatic attacks is really the focus. And monitoring for symptoms and lung functioning, learning to anticipate an asthmatic attack. Most individuals who have asthma, it's not something that they acquire in adulthood. It can be, however, it's oftentimes brought on very early in childhood, for example. So the individual learns to live with it over many, many years and possibly even certain decades. So they learn to anticipate an asthmatic attack and then treat it before it becomes too severe. It often begins during childhood and may last throughout one's life, and the cause really is not that clearly known. So the etiology is not that known, and what is known is that it's more common in individuals who also have allergies. The good news, however, is that asthma can be reversible. So in chronic bronchitis and in emphysema, we saw that the changes that took place, the morphological changes, the anatomical changes that took place, they were very, very difficult, if at all impossible, to reverse the damage. But in asthma has been shown that it can be reversible. So if inflammation in the bronchial tubes is not controlled, however, it can lead to respiratory changes that cannot be reversed. So they wind up being irreversible. This increases the risk of complications from lung as well as airway infections. And we see people who have these um, histories of COPDs, whether it be chronic bronchitis or emphysema or asthma, at higher risk for developing complications, whether it be complications related to, let's say, for example, a disease process like what we're seeing now with COVID-19. These individuals have underlying disease, so they are at much higher risk for developing respiratory issues related to complications and even necessitating ventilatory relief for COVID-19. However, as was mentioned, that these individuals wind up learning to live very effectively with their asthmatic state, provided that they carry their bronchodilator respiratory treatments with them, their inhalers. And it's always something that you want to emphasize to your patient, which is that if they are asthmatic or if they have a history of asthma, they should always carry their inhaler with them. It does them no good having their inhaler in their glove compartment or having their inhaler in their briefcase back in their office. They need to carry the inhaler with them, just like if they were to have an EpiPen carry with them. Now, this is a type of diagnostic procedure, which is a bronchoscopy, in which a bronchoscope is advanced past the nasal passages, past the airways, and it is used for visualization for checking any form of abnormalities. So this bronchoscope is inserted and it is passed into the nasopharynx, past the epiglottis, and enters into the trachea itself. And what you're doing is you're visualizing these bronchioles and these passageways. So you're looking for things like ulcerations, or you're looking for constrictures or polyps. And the good news is that with these types of procedures, you can biopsy the questionable tissue at the same time, so you can find out if there's any type of malignancies as well, or if, let's say, the questionable tissue is benign. So that being said, I just wanted to leave you guys with one last thing in relationship to COPD, because that's really what the disease process that we ended on. Now with COPD, I just want you to kind of picture the clinical picture of someone who has a history of COPD, which means that they've been dealing with it and living with it for many, many years. As the name implies, COPD, the C stands for chronic. So they have lasted with that disease for many, many years, if not a couple of decades. Remember, for these individuals, the stimulus to breathe is no longer the carbon dioxide level, it is the oxygen level. So what is very normal that occurs within every single emergency room in every single hospital across the United States is that when a person experiences respiratory distress, if they are dyspneic and they get rushed to the emergency room via ambulance, the first thing that anyone does when they see that someone is experiencing respiratory distress is they put oxygen on them, which is a very normal response. The problem is that if they put high liter flow oxygen, it becomes an issue for these people who have COPD. If they put anything above 2.5 liters or 3 liters per minute via nasal cannula on these individuals, it can wind up killing them because the oxygen sensors within the body, which wind up being the stimulus to breathe, wind up saying, oh my goodness, look at all this oxygen that is around. And we haven't seen this amount of oxygen in years. So what happens? Well, let's cut the stimulus to breathe. So this is what winds up occurring. The triage nurse, which is usually very, very busy, they see someone who's in respiratory distress, doesn't take an adequate history to find out that the patient's on COPD, and goes to attend to the actual emergency that's occurring, the code that's occurring, or what have you. They put them on high liter flow oxygen, like 4 liters per minute, 5 liters per minute. It calms down their respiratory rate from 33 to like 32. They come back, they check on the patient, they see, wow, the patient's doing much, much better. Their respiratory rate is 26. Then, they come back after maybe another 30 minutes, their respiratory rate is 20. Then ultimately, after another 30 minutes, their respiratory rate is 12, and then 8, and then 4, then eventually maybe 2 per hour. So 2 respirations per hour. You cannot live on 2 respirations per hour. And then finally, when the overworked ER nurse comes back to check on this patient, they are blue like a Smurf, and they're dead, and they're cold to touch. So with these people who have COPD, remember, this is extremely important, and a lot of nurses just don't get it. A lot of respiratory therapists don't even get it, which is that these people who have COPD, their stimulus to breathe is no longer the carbon dioxide level. Their stimulus to breathe is the oxygen level. So if you put them on high liter flow oxygen and you don't monitor them, they will eventually slow down their respirations until they stop breathing. Okay, so that being said, thank you guys for listening, and I apologize for the delay in posting this. Please stay safe, please stay healthy, and keep your loved ones safe. Thank you for all that you guys do, being out there on the front lines and being essential. And believe me, everyone appreciate it. Thank you.